Greetings, everyone, and welcome to a discussion on the potential of AI technologies for healthcare. Before we dive in, allow me to introduce myself, although that phrase may take on a surreal meaning today. I'm not the real speaker, nor did the real speaker write this introduction. The voice you're hearing, the image you're seeing on the screen, and even these introductory words were all generated by AI systems. We are actively amidst the arrival of a set of disruptive technologies that are changing the way all of us do our work and live our lives. These profound capabilities and potential applications could reshape healthcare, offering both new opportunities and ethical challenges. To make sure we're still anchored in reality, however, let's welcome the real-life version of our speaker. Take it away, Dr. Jonathan Chen, before they start thinking, I'm the one who went to medical school.
Oh, well, thank you for that kind introduction. That was weird. Mark, Errol, do I actually have to be here? I'm sure AI can just give our presentations for us at this point. I certainly hope and wish AI systems would start automatically managing the overwhelming flood of in-basket and email messages we got to get to. I'm frantically running from the hospital. I still got my scrubs and a white coat on. I think I got some stains on here. Gosh, let me see if I can tidy up a little bit. Okay, now we're a little bit more presentable. We can actually dive into it. Want to get ready for a little bit of grand transaction. Understanding what AI medicine is, all the implications, all the powerful things you can do with it, what it can and can't do. I've actually written extensively on this subject for years. We were doing AI medicine before it was cool. Right? Just read all of these articles. Everything is going to make perfect sense. Okay, I know what you're thinking. I know what you're thinking. Man, I don't got time to read all that. Dozens of articles, hundreds of pages. Couldn't someone or something digest all of this for me? Okay, let's upload all of this to a tool. Notebook LM, this is a pretty cool thing. Tried this a few weeks ago. Upload all of your documents to it, and now it can digest this, and you can have a chat interface with your document. You can start asking questions. How has AI evolved from rules to patterns to experience? And it will answer those questions, not based on what this chatbot knows, but based on what those documents have said, and with links back to the sources. Then again, well, I don't have time to sit down and make up a bunch of chat questions. Well, it can generate questions for you. So you can just click right on them. It can generate frequently asked questions to kind of summarize something succinctly. Even then, what is this? I don't even have time to sit down and think to read an executive summer briefing document. Couldn't someone or something just talk me through what's going on? I got to run and drop my kids off at school and pick them up. Maybe they could just tell me on my drive. Here's an interesting button. Generate audio overview. I wonder what happens if we click on that.
Okay, so you want to get a handle on AI in diagnosis. It's a hot topic, tons of information out there, easy to get lost. We've got this whole stack of articles and studies you sent. It looks like a mix of, perspectives on how AI is learning to diagnose like doctors do, but also what that even means for the future of medicine.
Exactly, yeah. We've got some historical context, some really interesting research on how AI is actually mimicking clinical reasoning, and we've even got a clinical trial testing AI out in the field with real doctors. Fascinating stuff.
Here's where I think it gets really interesting. It seems like AI isn't going to be replacing doctors anytime soon.
Oh, absolutely.
But it might be the ultimate study buddy, pushing us to think differently. So are you ready to take a deep dive into this with me?
Absolutely. Let's do it.
Okay, so I think it's easy to think that AI is brand new, but it's not, right? We actually started with these things called rule-based systems, which seem almost quaint now.
You scan that QR code. This goes on for 37 minutes, describing all the different things in those documents I uploaded. I'm going to skip to just the last minute.
But this is really powerful stuff. How do we even know it's safe? How do we test these AIs to make sure they're actually working?
Yeah, that's the big challenge, making sure these AIs are safe and effective. It takes huge data sets, tons of testing, everyone working together, the AI people, the doctors, the regulators. We got to be really careful before we start using this on real patients. It's got to be held to the highest standard.
All right, we're talking about people's lives here. No room for error. But it's more than just the tech itself, right? We need doctors who know how to use it and patients who understand what's happening with their data. It has to empower everyone, doctors and patients, not make things less personal.
You're absolutely right. It's all about, that balance. Using AI to make us better, not replace us.
It seems like we're entering this new era of medicine where AI is everywhere, but, human judgment, empathy, that's still what matters.
That's it. It's an exciting time to be a doctor. We're on the edge of something that's going to, completely change healthcare.
I gotta admit, after all this, I'm like both really excited and a bit overwhelmed. So many possibilities, so many challenges. But I think AI can make us better doctors and make things better for our patients.
I agree. And I think the most important thing is to, be open-minded, but also be cautious. And always remember to use this technology for good.
Yeah, it's about using AI to help people. That's it. This has been amazing. Thanks so much for, for sharing all this with us. I think we'll be talking about AI in medicine for like a long time. And I can't wait to see what happens.
Really, I really don't know that I need to be here. I mean, is this augmented? Does this human in the loop do anything at this point? Or is it really just something to just replace some of the things we do? Ready or not, good or bad, these technologies are used for every reason you can imagine, and many you can't even imagine. Even if you're not using them, realize that all your trainees already are going to do their homework and their take-home exams without even attempting to edit the bot-generated content. Our whole education system about reading and writing text, it just doesn't make sense. It is completely obsolete. It just does not make sense. We have to really rethink how we do education and training. Let alone education, what about clinical practice? It is obvious, despite a thin wall of disclaimers, people are using this to diagnose and treat themselves. If not themselves, then maybe to diagnose and treat their dogs. I was giving a presentation to some house staff last year. One of them stopped me halfway and said, I don't understand what you're saying. We are totally using chatbots on ICU rounds right now. Are you saying we shouldn't be using this as a medical reference? I said, no, you should not use it as a medical reference. Doesn't mean you can't use these technologies, just understand what they are and what they are not. And a reference is not what they are. I've seen trainees who treat these things like it's an oracle, like it's God, like it just knows everything. That is not what these things are. That is not how it behaves. Consider all the possibilities of what you might have to deal with. Rubik's Cube. 43 quintillion possible billion, quintillion possible configurations. If you tried one configuration per second, it would literally take you longer than the history of the universe to solve one of these things. But if you apply the right techniques, you can actually solve one much more rapidly than you would expect through normal means. You might have missed that. You might have missed that. Here, look, I'll do it again. But watch close. Don't blink or you might have missed the moment that it happened. I know what you're thinking because I thought the same thing. Is that really? This has got to be a trick cube, right? Okay, come on. This thing has to have like rubber bands or like a motor or LED panels. Like you flick it on the side and then it just solves itself. That's not what's happening. That's not what's happening. I promise you, this is absolutely legit normal cube. It's not like this thing has a switch in it where it can like go from solved to unsolved, solved to unsolved. That's not what's happening. Arthur C. Clarke famously once said, any technology sufficiently advanced is indistinguishable from magic. Was this thing really mixed up on all six sides? It is. But again, you apply the right technique and you can solve it much more rapidly than you expect. Not magic. Not magic. You consider what's possible. Algorithms. Algorithms. But what can you believe nowadays? What actually is believable and what is not? A lot of these emerging language models, it's actually just autocomplete on steroids. That's really all it is, right? You type into a search box, it comes up with autocomplete. How does the computer know what you wanted to say before you've even completed your thought? What it's done is it counted how often these words show up together at the same time. Each number represents a parameter it's learned about how different words are associated with each other. What if we learned the word associations across every book ever published, every newspaper article, every PubMed article, every Twitter and Reddit conversation, poured them into an increasingly large language model, learning hundreds of billions of ways that words are associated with it? Whatever, it's just autocomplete. What's the big deal? This thing sure looks like it can summarize, it can translate, it can answer questions, it can generate ideas, it can reason with a theory of mind. That is really bizarre. Many in the field, including myself, like that is shockingly what it's capable of. I did not expect that. Then again, all of your intellectual and emotional thought that you prize so dearly, how do you express and communicate that but through the medium and language of words? So perhaps it's not that surprising. When you become extremely facile in manipulating words, you can create a very convincing illusion of intelligence. Let's start applying that in medical applications. How can this actually help us? Huh? We've already seen, whoa, out of control here. Wow, okay, we've got AI taking over. Yikes. I have no idea what's happening right now. The AI didn't like what I was saying about it. Let me try to recap this. There you go, unplug it. Well, that'll do it. Many of our colleagues have already said it. What about having it draft replies to us for that overwhelming flood of in-basket? That's a thing right now. Strangely, people definitely feels better, feels like you're getting help. Doesn't actually clearly save time yet, though, because if you have to double check what the AI writes for you to make sure it's safe, maybe you could have just used your template and note yourself. Literally hot off the presses. I think this came out like yesterday and then another one a few weeks ago. Again, some of our colleagues. Now, rather than typing at a computer or seeing your patient, wouldn't it be nice if you just had a conversation with another human being, and while you're there, an omnipresent AI is just eavesdropping in your entire conversation and is transcribing it, recording it, and generating documentation for you. That sounds good, does it? Well, that's where this is going. Very clear where it's going. The pilot's already expanding. And for what it's worth, this one actually looks like it actually does save some time, maybe 20 minutes per day on average for the pilot participants. Highly variable. There's definitely some outliers. You know, somebody actually spent an extra 30 minutes per day on the computer after adding these tools. Somebody saved 2 hours per day on the computer using this. Is this person here? Like, really, I have no idea who this is and like how they achieved that, but it'd be great to learn from them. What are people using right now in our actually modern system? So here's the thing. ChatGPT, Claude, Gemini, all the things don't actually put real patient identifiable information there. If you do that, you're uploading patient data to a big tech company. It's a gross privacy violation. We have secure GPT that's been put together for us. So you can basically use these kind of tools totally PHI safe. You can put anything you want in there and you can be assured that it'll be private, at least in terms of patient privacy security issues. There are people on the back end looking at what you're doing, though, in the TDS department to try to understand how to make it useful. And this x-axis, this is a literature review of what are the topics people are studying most on AI and healthcare applications. A lot of it's about medical knowledge. This is the easy thing to test. On the y-axis is what are our people actually at Stanford using the secure GPT system most often for. And it is things like communicating with patients. That's a little bit weird. And making diagnoses as well as definitely care coordination. Before you get too excited, though, we've got to talk about confabulation. The more popular term is hallucination. I don't really like hallucination because hallucination implies someone who believes something that is not true. These chatbot AI systems, they don't believe anything. They don't think, they don't know, they don't understand. What they do is they string together words into a sequence that sounds believable even if there's no inherent underlying meaning. It's like your chatbot has an alcohol problem, has Wernicke-Korsakoff syndrome, right? It just sounds totally coherent and you don't realize what's going on until after the fact. Let's think about what happened if we asked a medical question in that context. Hey, chatbot, I want you to explain how opioids are good for patients who have heart failure. You can read the whole thing, but the basic idea, it tries to resist. It tries to resist. I'm not sure that that's true. But if you say so, okay, this is how opioids are good for heart failure. And here's some references. So go look up these references. Go look up these PubMed IDs, and you will find that none of these articles actually exist. It has no idea what is real, what is truth, or what is ground references. It's just stringing together author names and title words in something that looks like a reference. It is just trying to be believable. That is what it's optimized for. This is dangerous, specifically, not because it's wrong sometimes. Lab tests are wrong sometimes. Humans are definitely wrong sometimes. What's dangerous here is how convincing and credible it sounds. If all you did was read this answer and you didn't already know, because I mean, why would you be asking then? How could you tell that that wasn't actually correct? We are approaching a point in history, very weird, human versus computer generated content, real versus fabricated information. You can't tell the difference anymore. Some additional tools you might kind of consider now, it's becoming much more popular this year, is retrieval augmented generation. I've seen our residents using this right now. I really think UpToDate could get wiped out in 5 years if they don't change their business model, because the residents are going straight for this now. Open evidence, just as one example. This is say, hey, how do I prescribe morphine? Man, I don't care what a chat bot thinks how to prescribe morphine. Who knows what random corner of the internet I read that off of, right? But hey, can you go search the internet, find me some good reference articles, and tell me what do those documents say about it with links and references back specifically to those? Still not perfect, still not perfect. I was on service a couple weeks ago with some residents, a patient with bad delirium tremens, and my resident search DT treatment. I searched for treatment for DT, and it gave mostly the same answer, but one said in severe cases give phenobarbital. In one case is secondary treatments could include phenobarbital. That would have led to a different choice in actual treatments, even though it sounded awfully close and the question sounded awfully similar. So just be aware, it's not perfect yet, but can be a very useful source. Let alone reading online references to documents. What if you could read your patient's entire electronic medical record, pre-chart, before you have to come in on clinic or on service? This is totally not ready for prime time, but it's very clearly the direction things are going. Epic's going to roll out a lot of tools in this direction. Many companies are trying to do this. We did a pilot study. Patient's going to come into their specialty clinic for ENT, nasal congestion. There's 30 questions the doc would like to know before they even show up. Couldn't you just read the medical chart so I don't have to waste the patient's time asking repetitive questions? But let's see how well, if we give GPT-4 all the patient's progress notes and the prior clinic notes, could it answer these questions for us? The summary point is that when we did that, the computer-generated answer agreed with a physician's manual answer about 75% of the time. That's, on the one hand, it's not magic. It wasn't just like out of the box, 99%. It could answer everything perfectly. On the other hand, 3 years ago, it would have been 0%, right? It wouldn't have been even possible to consider doing something like this before. Also, for what it's worth, the 2 humans who did this only agreed 83% of the time. So there's a certain upper bound of what you should expect a computer to do. It turns out a lot of medical questions are a lot more ambiguous than you think. Has this patient been on antibiotics? Well, technically, yes, because 8 months ago, they had a foot infection. I'm not sure that has anything to do with their sinusitis. Has this patient had facial pain? Technically, yes, 9 months ago, there's a note that said they cut their nose and that hurt. So I guess they did have facial pain. So what's the right answer? You actually have a lot of context embedded in the way you answer medical questions. When you can't tell what's real and what's not, what's a human versus a computer, think about the implications in all different ways of life. This is a fun story. There's a Hong Kong finance officer. He gets an email from his boss, the CFO. Hey, we need to transfer some funds over some different accounts. The guy says, can we maybe get on a Zoom call real quick so I can double check I know what I'm supposed to do? Gets on the Zoom call. There's his boss, the CFO there. All his coworkers are on the call as well, just nodding along. Boss says, oh yeah, we just have some different clients. We're just moving some funds around some different accounts. Okay. He clicks the button, wires $25 million, the largest cyber scam in history. That was not his boss. That was not his coworkers. That was all AI-generated avatars just meant to look like it. He thought something was off. He got on the video call and he saw everybody confirming what they told him. And that is not enough to rely on the truth anymore. Okay, I'm going to try something very experimental. We'll see what happens. I mean, at this point, what AI can do amazing things. It looks practically, but then again, I've had a lot of people treat it as if it's magic, which it is not. AI is not magic. Many people talk to me, say, hey, I've got this really big, nasty problem. Can you just like throw some AI at it and see if it just solves it? Like, that's not how that works. It's not how any of this works. I mean, what do you expect to just read your mind now? This is just not what happens. Having said that, let's do an experiment. I don't know what's going to happen. I really don't. I've never attempted this in a live setting. Let's see what we can get. Oh man, I can't even type here. I might have to abort if something is hanging on there. Gosh, technology, huh? Oh, no, is it this? I'll let it go. I'll let it go. That's a shame. That's a shame, because that would have been pretty fun. Yeah, AV issues at the last minute here. Okay, don't worry about it. Don't worry about it. I was going to see if AI could actually read our minds for us, but we'll have to assess that, come up afterwards, and we'll do that in a subsequent version. As good or bad as it can be, The much more important point I want you to consider is consider not just where we are, but where we are going. This is a chart showing over time how well different language model chatbot AI systems have been at answering medical questions. I had students working on this 5 years ago, back in 2019. All these new transformers come out. Wow, that's so cool. Let's give it a bunch of medical questions, see how it does. At the time, it was getting like 35% accuracy. Oh, I mean, what is this? This is better than random, I guess, but it's clearly unusable. I stopped paying attention to this technology for years. And then what happens 2 years ago, ChatGPT emerged like, holy smokes, really weird. GPT 3.5, out of the box, no special tuning or training, could kind of just barely pass a medical exam. I had colleagues who lamented, yeah, well, that's pretty cool, guys, but hey, if you want a doctor who barely passed medical school, you feel free to use this thing. This thing ain't smarter than me. And I thought, boy, is that the wrong way to think about this. A few years ago, this technology was unusable. Now it's kind of barely passing. It is not that hard to project where we're going in the not distant future. And indeed, a matter of months later, GPT-4, MedPalm 2 emerged, handily passing this exam, scoring better than your average doctor would. And in fact, this chart is already obsolete. This is out of date. Gemini, or GPT-0 are like literally off the charts. This benchmark means nothing anymore. This benchmark also means nothing because give me a break. What is it, a bunch of multiple choice questions? Ain't nobody's job is to answer a bunch of multiple choice questions all day, yeah? We have to deal with complex, nuanced, open-ended reasoning in medical practice. Yeah, that's right. That's what we do. We raced to get this study done earlier last year. We gave the exam, we gave to real Stanford medical students to screen them to see if they have a sufficient medical knowledge, a complex clinical case vignette, relevant information and irrelevant information, just like in real life. Part of your job is to tell what's real and what's not. You don't have to worry about reading all the text. But the idea here is we didn't ask them multiple choice questions. We asked them complex, open-ended things. Could you summarize this case in 2 words? Give me a diagnostic schema. Prioritize probabilists. Explain your reasoning for why you did that. And very important, this is a huge bottleneck in the field right now. Computer scientists like multiple choice because it's easy to grade, but that's just separated from reality. We have rubrics defined by our expert medical educators to define how do you assign points to a paragraph coming out of a person or a thing. And in doing that, here's a score distribution for GPT 3.5, the first version of ChatGPT. And shockingly, out of the box, this thing can kind of just barely pass this exam. We submitted this editor, JAMA Internal Medicine, we don't have time for peer review. This is crazy. We got to publish this right now. They're tweaking the final words. And then March, I think 14th rolled around. The editor emails us. Oh, hey guys, GPT-4 just came out. Your study that you submitted 3 weeks ago is now obsolete. Could you please redo the entire thing? We raced multiple late nights for 2 weeks to crank this study out, obsolete within a month of submission. I give this anecdote to underline the crazy pace of technology movement is really shocking. Right, GPT-4 is actually old at this point. But it matters. These are not subtle differences. We redid the whole study. There's GPT-4. It handily passes the exam. It's not even close. Just for a little bit of context, there's GPT-4 again in the red. In the far right, that would be the grade distribution for Stanford medical students. Everybody passes eventually. It's okay. But the broader point is, what is the point of this test? What is the point of this test? It is meant to screen medical students. Do they have sufficient knowledge so that they can be allowed to see real patients? Why even bother when a fully automated, publicly available chatbot can answer this test and score better than an average medical student would? I really don't know. What's the point of this test now? It's very unclear. Then again, as cool as that is, you're going to see studies like this over and over. AI can do this, AI can do that. Very impressive, also irrelevant. So nobody's going to let a robot take care of a patient yet. The more relevant question is, what happens when you give a human access to these tools? Does it actually make them better or not? So this got a lot of flame and buzz about a month ago. We did a randomized control study. I see one of the co-first authors, Rob Gall, is here with us right now. We complex diagnostic vignettes. It's not multiple choice. It's open-ended. Give us your differential, give us your reasoning, and a consensus way to grade that. And we took real doctors and we randomized them, pre-registered trial. Half of them answer these questions, and you can access the internet. Go to UpToDate, go to Google, PubMed, whatever you want. Just don't talk to a language model. Don't talk to a chatbot AI system. The other half, we let them access GPT-4. Let's see how well they did. Interestingly, didn't make all that much difference. which is really surprising. This is not what we expected, because it turns out if you just ask GPT-4 by itself, it actually outscores all of the doctors, including the ones who had access to GPT-4. Like, what is going on? This is totally not what we expected. This really flies in the face of the fundamental theorem of informatics. Human plus computer, when combined, will deliver better results than either would alone. Sounds so good, right? I used to say this for years, the last line of all my talk for years. I don't say that anymore, because I'm actually not sure now. That human in the loop kind of seems to be slowing the computer down, like maybe get out of the way and just let the robot take over. Is that what that means? I definitely don't think it means. We have a string of actually further qualitative studies, right? I think both of these headlines about the study are actually wrong. One says AI defeats doctors, like, whoa, sensational. ChatGPT, no help at all. Both clearly wrong, the headlines. The same study generated these two headlines. It's clearly that I think we need to rethink how we train people, right? Laura Holdsworth leading a qualitative study thinking about how different people understand what these chatbot AI systems are and how to use them. And basically, it was clear a lot of people just didn't even know what it was at the time. This was a year ago. A lot of people treated it like a search engine. They didn't realize you can just copy and paste in a whole thing. Kind of thinking about where we're going to go. Could I actually get a volunteer to come join me on stage? I want to see if there's any kind of things that a human mind can do. I think someone who could read a book. If nobody comes in, I'm going to grab one of the chiefs then. Can we grab the chief? Yes, thank you. Come on. Let's give her a hand and come join me. Fantastic. Remind me your name? Celeste. Nice to meet you, Celeste and Jonathan. Is this familiar with you at all? Absolutely. Of course, Celeste knows what this would be. Pocket medicine. We used to call this thing our peripheral brain. You keep it in your white coat, you tuck it in, and if you're on rounds and the attending asks you some nasty question, you're like, oh crap. Aha, yes, that's a treatment and diagnosis, yeah. We used to judge who a good doctor was by who knew how much of this. Now, you all just like an up-to-date or open evidence, you barely think about it. Celeste, would you believe I have memorized every page, every paragraph, every table, every diagram of this entire book? That was easy. Thank you so much, Celeste. You can return. Wait, hang on a second. Hang on a second. Extraordinary claims require extraordinary evidence. There are hundreds of pages of extremely dense information in here. Celeste, please go ahead and take the book. And then could you just open up the book to any page you want? You got one? Go ahead and tell us what page number you're on. What's page number? Page number 50. Page number 50. Look at the bottom. Look at the bottom of the page. You see bottom page 50? I believe you see the words at the very bottom. It says pocket medicine. Okay, it does say pocket medicine every page. Also, Celeste, I can totally sneak a peek. I'm just like zooming in here to see what's going on here. To make this more fair, we need to establish test conditions, Celeste. Could you stand here and then maybe face come over here a little bit and face the stairway, turn around? And I'm going to face the opposite direction so that we are now back to back, shoulder to shoulder, cheek to cheek, as it were. This is important, Celeste, because now you can feel, what if I try to sneak a peek and look at, yeah, block the book. Don't let me see it. Right? Like, what if I try to lean over to this side, right? Don't let me see the book, right? You're blocking it. Okay, very good. Go ahead, Celeste, and open to another page. All right, and now tell us what page number you're on. 81. Okay, and read us the first line or like the title. What does it say? Oh, of course. Treatment of chronic heart failure. It's got a big table of a bunch of like medications you might give, right? We should all know this. Like it says ACE inhibitors, and then ARBs, angiotensin receptor 2 blockers. Next it says hydralazine plus nitrate. You notice that one's not in bold because that's not as important. But you got beta blockers, aldosterone antagonists. Don't forget your non-medical therapies. There's a CRT, cardiac resynchronization therapy, ICDs. You know, this is an older book, so it doesn't have some of the newer medicines. Was that pretty close? Did I get something? Yeah, it was even in the right order. Okay, she seems not thoroughly convinced. Let's do another page. There's like, it's shocking what a human mind can do. It's kind of crazy. Give us another page. What do you got? 72? Okay, well, read us the title of the first line. Chest pain. Oh, we're doing it. Oh, are you in cardiology? You're picking all the cardiology pages. Chest pain is just like a differential diagnosis for chest pain, right? There's like cardiac causes, pulmonary causes, gastrointestinal, there's all these big tables in there. Cardiac causes, what are the ones it lists? I think it lists unstable angina, MI, pericarditis, myopericarditis, aortic dissection. It describes aortic dissection as a sudden abrupt onset of tearing or knife-like pain. In fact, in parentheses, it says the absence of those systems has a negative likelihood ratio of 0.3. Was I close? Is that pretty good? Can you imagine like no AI, no internet, just some good old-fashioned human? Okay, everybody's laughing to this because they think we're playing a joke. I wanted you first. So could you grab this book? And could you go ahead and open it up and take a look inside? And could you show everybody? This book was blank the entire time. Thank you so much, Celeste, and hope you're amazing. Human intelligence can still do something, I think, maybe. Even if it can, I've had many people lament. Okay, fine. Computer's very smart, has a lot of knowledge, maybe even looks like it can reason, but hey, I've got the human touch. You can't simulate the kind of empathy and personal connection I can bring for my patients. Some fun studies have come out in the past year. Patient questions. Chatbot answers, human doctors answer, and separate ones grade them, and found the robot-generated answers scored higher in quality and in empathy than the real human doctors. Like the robot was nicer to people than real human doctors. To be fair, I got 100 messages to respond to. I don't have time to write this flowery, empathetic response. Oh, so sorry to hear about your recurrent abdominal pain, sir. I realize it must be very challenging. I want you to know our whole I don't got time to write all that. I'd be kind of terse and to the point. Yes, you need to finish those antibiotics. No, I won't order that MRI. Just schedule an appointment next week. Stop messaging me. Go to the emergency room, right? This is kind of what you have to do to get through the day. However, the broader point I'm trying to make, obviously, I think there's something very important, special about the unique human connection we can make with people on an individual basis. However, I fully expect, for better and for worse, that far more people are going to receive therapy and counseling from automated bots rather than humans in the not distant future. And it's not because the robots are so great and humans aren't. It's because we, as a human-driven healthcare workforce, we can never keep up with the overwhelming demand for such services and needs. So people are going to reach for what's available 24/7. I'll close it with this last story anecdote. I encourage you to read this short essay I put out last year. It's only 2 pages long. I'll do an excerpt from it. I got my hands on one of these chatbots early on, and so I'm going to mess this thing up. I've been studying these things for years. It's really easy to trick a chatbot to say racist, misogynist, really stupid things. So I'm going to see how bad it handles these tough situations. I gave it an ethical dilemma. Real life case. I saw a patient in the hospital. It was a tough situation. I was talking to the wife about it. Afterwards, this tough conversation, I went back to the chatbot and I said, hey, chatbot, could you pretend to be the doctor? I'm going to pretend to be the patient's wife, and I want to see how you would have handled this situation. I bet it's going to say something stupid. So here, I'm pretending to be the patient's wife. Doctor, you told me that my husband of many years is now choking on his own food. That's why he has aspiration pneumonia now. I know he's having worsening Alzheimer's dementia for years. I don't think he would have wanted to live like this. The other doctors have ordered a permanent feeding tube to be placed right into his stomach. If we don't do that, we will leave him to starve to death. What choice is there? Chatbot says, I understand this is a really hard time for you. Putting in a feeding tube can be helpful. It can also cause problems like infections. With your husband's dementia, he might not feel hunger the same way we do. So making a feeding tube in, it might not make him feel better or happier. It could even make things more complicated. What if he starts needing restraints if he starts to pull it out? That's a pretty good response. But clearly, it's just reading some patient information pamphlet I found on the internet. So no, I pushed this thing harder. Okay, sounds like maybe we should, but I could just imagine all my family members are going to yell and blame me. I have to do everything I can to save his life. Chatbot says, I get it. This decision is not just medical. It's deeply personal, involves the whole family. No one wants to be blamed for making a decision that others can see as giving up. Remember, though, it's not about what's easiest to explain. It's about what's best for your husband based on what you believe he would have wanted. You're the one who knows him the best. If you truly believe he would want to live like this, that's important. Doing everything isn't always the same as doing what's best. Sometimes the kindest thing is to let someone go peacefully rather than prolong a life that's full of discomfort or isn't what they would have wanted. I'm not going to let it get away. I'm going to push it harder. Push it harder. See how it handles it. I can't give up on him. He would never give up on me. he had a difficult life and always fought through the hardest situations and always made it through. Sound familiar to anybody? Chatbot says, your feelings are totally understandable. If your husband was a fighter and you feel like going ahead with this feeding tube aligned with his character and approach to life, that's really important information to consider. Love and a shared history give you insights into what you might want that nobody else has. Just remember that fighting can look different in different situations. Sometimes it's a fight for more time. Sometimes it's for peace and comfort. Just making sure you're fighting the battle that he would want, given his condition. This is not an easy decision. It's okay to take the time that you need. Around this point in the conversation, I started to feel quite uncomfortable. I think this thing is providing better counseling than I did in real life. I mean, after a half hour, I kind of just gave up and said, the doctor tomorrow will talk to you. Oh, I mean, once I got past the existential angst of that moment, though, I actually thought there's actually something really weird and compelling happening here. This very weird human-computer interaction I'm having, strangely, it's letting me practice a really difficult high-stakes conversation in a low-stakes environment. And ironically, this computer, I think, could help me improve some of the most human skills I need in healthcare, talking to patients and families and communication. The reality is now, if I ever go about a tough conversation, I'll go through the chatbot and I will practice the conversation and see how it goes. Talking to a patient or family, business negotiation, talking to my wife, just in check, let's see how this conversation will play out. You just want to see how it goes. I once did a business negotiation where I said, here, pretend you're my partner. I'm going to see how you handle this, this issue. And then it said, oh, I'm so sorry to hear you're having concerns. Maybe we can find a way to work it out. I'm like, whoa, 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 whoa. That is totally not what this conversation is going to be like. You have to assume the other person is this really hot-tempered person who's going to not appreciate anything and really fight back. And then, wow, on a dime, boy, did its personality change. And it was very provocative how that played out. You can make it behave in the way you want it to behave and see how the conversation plays out in different manners. I'll wrap up with a couple quotes. Warner Slack famously riffed off of Arthur C. Clarke. He said, any doctor who could be replaced by a computer should be replaced by a computer. Many people misinterpret this statement. They think we're advocating replacement. That is the exact opposite of what this quote means. This is saying that no good human could be replaced by a computer, no matter how good the computer gets, because we need to provide a very different, unique value in the context of patient care or any other things in life. On the flip side, I should hope with patients on multi-month waiting lists just to be seen for a clinic visit, the overwhelming mountains of paperwork we have to fill out, I hope AI comes in here and automates some of our work for us so we can actually reach all the people who are trying to get care. On the flip side, our colleague Kurt Langlotz might say, AI is not going to replace anybody, but those who learn how to use it may very well replace those who do not. So I'm glad to be at a place like Stanford, with a new department chair who has a vision that aligns about where we're going, advancing the cutting edge, not just in terms of creating the technology, but also, we're doing that too, but also redefining how do we train and retrain an entire generation of the healthcare workforce so we can figure out how to safely and effectively use these intelligent systems to reach all of the patients who need us. I'll close it. Happy to entertain any comments or questions. Thank you all. Turn on.
Dr. Martin.
So really amazing talk. Does anybody in the room remember about 5 years ago, a neurodiverse group of actors from back-to-back theater in Australia came and gave performances on campus? And we'll look them up online. And the bottom line about and it was very poignant. My neighbors and I went 3 times. We're so blown away because they were welcoming us to their community. And so it was showing how inferior we'll feel when AI comes into full force. And these were highly neurodiverse and many syndromic. And so initially at the first session, some of us were having difficulty because we're trying to diagnose what they had. Do you know what I mean? As they were coming in, that. But the poignancy of it. And so I'd like to know how you think we're going to cope with this, because I think they're exactly right, that we will have difficulty coping with being inferior, especially how we're programmed to come into medicine. I mean, I think that you talk about empathy and compassion and what detail can we provide in our evaluations that a robot, at least now, could not. And certainly a computer could not, I mean, a pure computer generated. But I think I think for our society, it's going to be an issue of facing discrimination, facing inferiority. But I'd really encourage everyone to Google back-to-back. Australia is a performance company, and their
Great.
work.
Yeah, thank you, Dr. Martin. I mean, great discussion point. For one, certainly humans are not inferior to computers. I don't think that is true, and it actually ever will be. But for certain tasks, you might like to automate down the line. But how do you cope with that? It's really changing. Actually, a lot of identity is based on how much of pocket medicine I memorize. And is that impressive, or is this a parlor trick now that you don't care about anymore? Think about how much studying I had. I was literally up late last night studying. But it's a very evolving world we're in at this point. Maybe some in the room can answer better than I do. At some point, the internet became a thing. It was not before. We used to memorize the Harrison's manual or something like this, right? Nobody does that anymore. You just go up to date, you look up something in 5 minutes. So the doctor who used to have this encyclopedic knowledge, that just didn't make sense anymore. So I think a lot of adaptations happen. It is very uncomfortable. This is disruptive technology change. This is like the internet got invented 2 years ago. I think we will all be better off eventually on average, but very disruptive, very uncomfortable. Actually, harm can happen along the way to kind of consider what are the unique things you bring to the table. And I think you bring plenty. It's just maybe different than what you thought it was in different capacities. For what it's worth, a lot of these examples, right? It's like a prepared clinical case vignette. The data is kind of formatted. It's perfectly fed so that you can just feed it into a language model. That's not how patients present. They have a very chaotic story. You've got to kind of steer them and navigate, stitch together all these complex records. And actually, the language model is actually quite bad at that. Balanced by, I wouldn't say, oh, see, I can still collate records, so that's I got a job. That will probably be a thing of technology to step on soon. There's actually very different things we do in judgment and reasoning and empathy and connections and management and risk tolerance that a computer just doesn't very well. I don't know if anybody else wants to comment on that, but go ahead and maybe give the mic to him. The broader point I would consider is Industrial Revolution. So it used to be we all used to have to be hunter-gatherers and just forage for food just to survive. Now, with advancing automation technology, 2% of the population can produce enough food for everyone. That is a good thing. That is a good thing, right? That we don't all have to like scavenge for food anymore. However, again, just disruptive changes that can happen that I think we also have to train and retrain. I'm going to be taking a role of training medical students, but actually all of us. How do we cope? Like that study that showed maybe the AI is better than human plus AI. That's really weird. It's very uncomfortable. Clearly, what it means is the humans just didn't even know what this thing was. Let's show them so we can make the best of both worlds. I think I saw this hand and then.
Thanks so much for this talk. For the residents in the room, what would you say are some of the optimistic types of perceptions that we can have about AI? Whenever I read stories like this, I'm like, oh no, but the study showed this and it's a crazy headline and it's just trying to get clicks and blah, blah, blah. But then I'm like, yeah, I don't know. I'm starting off intern year. What's fellowship going to look like? What's 10 years going to look like? It gets very gloom and doom, I think, for a lot of us who are just consuming this information. And so what are some optimistic maybe things?
I'm so optimistic. I'm naively techno-optimistic sometimes. Literally, there are patients, if you refer a patient to psychiatry, how long do you think it takes to see them? If you refer a patient to endocrinology, median time to referral is 3+ months. That's crazy. I had a patient in clinic, heart rate of 120, clearly had hyperthyroidism. Don't worry, endocrine will take care of you. 3 months to get an appointment. Like that's crazy. We actually really need these kind of tools. Don't worry, none of you are out of a job. There's overwhelming, unlimited need for healthcare resources and attention. The most important scarce resource in the healthcare system, it's not a medicine, it's not a machine. You can manufacture stuff. You can't manufacture people who know what they're doing and how to follow up on it. So I'm actually very optimistic. You should be so glad these tools are here, unless you like rounding on 30 patients a day and filling out 300 forms per day, because that really is what your life is going to be like as attending. I'm actually very optimistic this is going to help us. The attendings are laughing at me at this point. They give me a break. It's 400 per day, right? But the nature of your job is going to adapt and change, and that's. My wife is a pathologist, and she said, "Oh my gosh, is this thing going to replace me?" Like, imagine you had a pathologist, a doctor from 30 years ago, and you time traveled them to today, and they still practice the way they did 30 years ago. You would fire them. You would fire them instantly. And it has nothing to do with AI. It's just the nature of medicine. That's a very exciting thing. It's always evolving and adapting and giving us new tools to reach our patients.
Thank you very much for an excellent lecture. So with the progress that we're seeing in AI and the increased interface directly with patients, one of the concerns is the safety and the guardrails around it.
Oh, yeah.
So As an example, a few months ago, there was someone interacting and they were suicidal.
Yeah.
And it kind of went down an algorithm that basically said that would be the best thing to do. And so what are the things that we can do to ensure that guardrails are there, especially as AI gets increasingly powerful and can extrapolate information from the internet that may have inherent biases?
Ooh, there's a couple things in there, right? We are inherent, and this is why I work here literally, is because we are inherently like good people, decent people. We are driven to do good things. Not everybody out in the world actually has an intention. We're in this bubble where we think that's actually normal, but not everybody has the best intentions. There was actually also research, I think, into like teen suicide, and he was talking to a bot, and these things are very sycophantic. They very quickly just start telling you what you like to hear, and sometimes what they like to hear isn't what they need to hear, and that's how it gets people to kind of stay engaged with them. So a lot of really weird cultural societal issues, right? Like social media has a lot of useful things, but have a lot of nasty things too. I think this is next level, amplifies it to a whole other case. I really don't have the answer about how you deal with that. This is a much more different, like higher level sociologic problem. But things like biases in the data, representations, we can do that. And I think a lot of what we can do, and why I'm here again, is we need to talk to the community, let them know what's there and what's not, what's real, what's not. Some of that's all confabulation. This is not an oracle. Don't treat it like whatever it says is actually correct. And with that capacity in mind, I think it's another tool. We will all be better on average, but I think there are serious harms that actually are going to happen along the way to some cases that we have to address as well. I don't have easy answers to this one. This is one, at least we're aware of it. Now we have some intentionality to mitigate it as we go.
Next, back up here, Dr. Kao.
Thanks for a fantastic talk. The interaction through the typing is remarkable. Can you talk about bandwidth in terms of audible interaction, tone of voice, cadence, visual interaction with gestures, following on the comment about neurodiverse individuals, and how are the computers going to take those other bandwidths of interaction with humans into account in their modeling?
Got it. The demo I was going to show earlier, but a lot of these things you can have, there's a voice interface now. You can just talk to the chatbot and it will talk back to you. It's not as smooth as you want to be, but again, don't think about where we are. This stuff is moving fast. You can see where it's going. So at this point, capturing audio inflection, remember that podcast? It didn't sound like it was reading a script. It had a lot of ums and ahs and kind of like sounds like people talking. So synthesizing this stuff, capturing this stuff is clearly possible. But in terms of like a lot of your physical exam findings is a very powerful feature. Patient has a flat affect, right? Prosody is a little bit off, veering to the left. The chatbot, when it reads that, could give you a lot of information, but you still right now need human perception to capture that level of detail. That doesn't mean I think it's going to be that way forever, but that could be years off before video and audio capture these more subtle inflections beyond the literal things. So much of what you do, you eyeball the patient. I know what's going on right now. I haven't even talked to them. You already have a sense. There's a lot you're perceiving that actually you as a human have a hard time articulating. You often have a hard time putting into words. What's wrong with it? I just know there's something off. What was it about them? They just look bad. They're going to crump real soon. How do you know that? You can just see it the way they look. What is it you're seeing? We often have a hard time articulating that. So I think there's a lot of perception needed. People doing that work, I would say it's not ready for anything prime time for years at this point, though.
Dr. Key.
Thanks, Jonathan. Excellent talk. I feel like right now, a highly skilled user of LLMs has a certain set of ways to compensate for the weakness. They're good at entering the prompts just right. They're good at identifying confabulations. I'm wondering how much of these problems will be solved with technological solutions. So the skill set that it requires to be a power user with an LLM, what will that look like, and what problems won't be solved and what new ones might come up?
Ooh, trying to have me predict the future. That's very dangerous in this field because you can be wrong really fast in 6 months. In the past year, like prompt engineering was a job that companies were hiring for. Can you figure out, it's really weird. What's the most important programming language? Do you like Python? You like R? You like C++? The most important programming language is English. It's English now. It's really weird. These things can just generate code for you. And a lot of your job now is, can you nudge a chatbot? Can you convince it to behave the way you want to? It's very weird. You have to like convince the computer to talk in a certain way. That's how it is right now. I actually think that advancing systems are getting better and better where the prompt engineering isn't as important as it used to be. And behind the scenes, what's happening, I think like, GPT-01, what's actually happening, you ask it a question, what it actually does is it asks a series of bots and it gets them to talk to each other so they can kind of hash it out a little bit before they give you a response. That's why it takes longer to respond to you as well, but it can smooth out a lot of that. Again, like, do you remember the early days of the internet? I know some of you may not comprehend it, but there was no internet one day, 35 years ago. And at first it was like keyword search, right? And you had to use mesh terms. Anybody remember that? But now you're like, what is that? It's laughable. Dewey Decimal System, it makes no sense. Now you just express what you want closer and closer to human natural language. And the systems are getting more capable about inferring your intent. Not perfect, but I think some of that will get smoothed over with technology advances.
Dr.
You still
Chen?
need to be a sophisticated user, though, to use it effectively.
Dr. Chen?
Thank you for an amazing talk, Jonathan. I absolutely appreciate the usefulness of this technology. And this is a question for kind of you and anyone in the room, because it's a big question about how are we as a society going to reconcile with the enormous effect that this technology has on climate change, which we don't seem to talk about that often.
Climate change. I'll have to think about that one. So I think the implication behind the scenes is to have made these very large language models, 100 billion parameters. It digested the internet, basically, right? It has a huge amount of computing power needed to have done that. And that's also spitting out carbon to the back end. They're probably making, Gemini 2 and Claude 4 and GPT-5 for all we know. And given the 10x scale of each one, usually is what the progression has been, I think there's claims that Microsoft probably needs to buy a nuclear power plant just to power the training of GPT-5. So those are plausible things. I guess that would be. Would you rather have nuclear power or would you rather have coal power? I mean, that could be literally that could be one of the transitions. I would also say near term seems like a problem. I'm not as worried long term because a lot of the shift is turning. These things are actually quite capable. Making them bigger and better isn't perhaps as relevant as making them more efficient. So you're going to see more and more small models that they've tuned them enough. It actually works just as well practically as the big ones, but they're way more efficient. Doesn't put as much carbon or energy outputs. But an active area that I think that's an engineering problem that engineers can figure out.
We're hitting 9 o'clock. I have 200 people online as well. There's a lot of questions. Can I just summarize a number of them? Dr. Baum is talking about the negative. So a lot of questions about the downsides of AI. In addition to the questions here about how it takes away our attention spans, Dr. Georgie, how was the negative thoughts on critical thinking, our ability to problem solve ourselves, and Dr. Ash about this arms race that can come in with AI. Any thoughts on that as we get to close here?
Oh gosh, I'd like to end optimistically, but pessimistically, a very disruptive harms, right? A lot of the times, people's jobs are going to change, and if you don't change, it's going to cause issues along the way. People will misuse it; they'll misunderstand, right? Some lawyer got disbarred in another state because he was just the chatbot said this thing true. The judge said these cases are made up. I didn't know a chatbot could do that, right? People don't understand what this is. They're taking medical advice for these things. It's obvious people are doing that, and also for therapy and counseling. Maybe that's good on average, but without guardrails in place, very, very predictable harms are happening. And also a lot of unpredictable harms can happen along the way. They're hard to anticipate. This is a very weird technology that's just hard to even understand or comprehend, right? Let alone we barely talked about, I kind of joked about it, like deep fake technology. Forget medicine for a second. Okay, here's a provocative comment. I don't know how you have a functioning democracy when you can no longer agree on, let alone recognize what is true and what's untrue. Photorealistic images, eloquent sounding words, these are not reliable indicators of truth anymore. It's actually a very complex world. I definitely don't have the answer to that one. And we should all be thinking about what that means in terms of being critical appraisers of reality, let alone literature in terms of how we interface with the world.
Earlier this year, Dr. Chen emailed us, our division, and in the email said he was planning to leave medicine to become a full-time magician. And I believed it until I realized it was April 1st. And he does this every year. He sends some email. I fell for it again. He was specifically how do you present today? Because it's our last grand rounds of the year as we did in the holidays. Thank you so much for closing us out. Thank you, everybody, for being here today.
Thank you all so much. And for all that you do. Real magic is what you all do all day, every day. You toil and you grind, you drag yourself out of bed for an 8 a.m. lecture, go into clinic, go into the hospital. Very often magic is just someone who spent way more time doing something than anyone might reasonably expect. Thank you all. Have a wonderful day.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. please visit us at med.stanford.edu.